Hello everyone, how are you all? My name is Rabi. I'm one of the tutors working with First Aid AMC course. So I'm very glad that a large number of people has joined us. So today we will be doing a trial class of the recent recall questions that came in the April exam. So hello, good evening. A little bit about myself. My name is Rabia Farid, and I have been working with First Aid AMC since 2021 after I passed my exam. I did take the course myself, both the AMC MCQ course and clinical course, and I passed both my exams in first attempt, and I'm currently working in Australian health system for the past 3 months as a resident medical officer. So coming from a person's perspective who has gone through every part of the journey that you are about to embark on, I really welcome all of you and would encourage you to join this course, as it has greatly helped not only me, but thousands of students pass the exam, get oriented to the Australian health system and how to get a job and how to be a part of the Australian health system if that is your direction of working in the future. Hello, Dr. Cheyenne, how are you? So a little bit that I would like to tell you about the course is that the First Aid AMC, it offers MCQ course and clinical course of about 5 months. It's an online course, so most of the classes will be online, just like we are taking with the Zoom. You can join the live classes, and the good thing about the course is that if you are unable to join the live class, there are recordings available of that class in your software for you to get access of whenever it is suitable according to your timetable. Not only the classes, there are a number of MCQ recalls from about 2019 up till now that have been solved with explanation available in the software. In the software of the First Aid AMC course, we also have mock test available. After every completion of a specific system, there are specific mock tests available regarding that system, and then there are mock tests available according to the year, and then there are grand mock tests available for you to take to orient yourself in the time management for the exam. So a bit about the exam. So AMC stands for Australian Medical Council, and this is a license registration exam. So in order for you to practice in Australia, coming through the standard pathway, you have to give this exam. Otherwise, you will be ineligible to work in the Australian health system. So the first exam is the MCQ exam, and the second exam is the clinical exam, much like the OSCE that we have gone through when we were in our medical schools. The MCQ exam consists of 150 MCQs, out of which 100 MCQs are marked and 50 are just trial MCQs. And the marking depends upon the type of the question. So some of the question will contain 2 or 3 marks, and some questions will contain 4 and 5 marks. There is no negative marking in this. And in order to pass the exam, you have to score more than 250 in the exam. All right. So the MCQ exam is a theoretical exam. It's mainly based on the theoretical knowledge of medicine, surgery, gynecology and obstetrics, and pediatrics, along with the population health. It sounds like it's a lot of things for you guys to study, but believe me, you guys have already studied everything relating to this exam in your medical school. So you just need to revise everything in this course. We will help you to revise the basics of your medical school according to the Australian health system. And then you will be able to be equipped with the knowledge in order to sit the exam. Can you guys hear me now? I have tried to up the volume. Okay. All right. So Dr. Arshan is the main tutor who is going to be taking your theoretical classes, especially the ones with the cardiology subject-wise. Yes, we do have system-wise recalls in the software as well, Dr. Momita. So Dr. Arshan is the main tutor who is going to be taking maximum number of classes. We have 3 classes in a week, sometimes 2, because all of the tutors who are working for the state AMC course are also working in the hospital. So sometimes the classes can vary, but we try to be as consistent as possible for you guys, okay? So he's the main tutor who is going to be taking maximum number of classes. He will be going system-wise, while there are other 2 tutors. That is only available in the software, Dr. Shahid. All right. Other than Dr. Arshan, it's me who will be taking your recall session, and Dr. Mukaddas, who is also a tutor associated with us, who will be taking the recall classes. And we will be alternating and discussing the recent recalls which are coming in the exam. Also, we don't only discuss the recalls, we also help you with the tips and tricks about how to save the time and select the best option available. Now, whenever my students ask me what's the best way to study for the exam, I always tell them to study John Murtagh, which will be covered by Dr. Arshan. Secondly, check the Australian health guidelines. Now, there are several guidelines that you can study. ULD health guidelines is the Queensland health ones. You can study RCH guidelines, which is for the pediatric emergency cases. You can study SA health guideline for obs and gynae. They have very good flowcharts available for the emergency cases of the obstetrics and gynecological cases. You can study NPS. And you can also study Better Health Victoria guidelines. Now, this is just a review of the guidelines that we usually use as a reference in our recall classes. You guys can also get med bullets, which is, I think, USMLE book, but they are very good in the hematology. So I would recommend you guys to study the hematology from the med bullets. So this is the basics of the AMC MCQ exam that you need to study from. And always try to study from the latest edition of the Murtagh, because the clinical guidelines, they are changing after every 6 months. So you need to be a bit updated if you are taking more than 6 months in your exam preparation. Any questions up till now, guys? Any queries you have in your mind? I'm happy to help you out with anything. All right, so let's start with today's class. The recalls are taken from the recent April exam that have been conducted. And we collect the questions from the candidates, and we try to make a sense of it, because sometimes the recaller doesn't remember all the information. But if they remember the key point, then we try to get it out to you guys as much as possible. You can't get the lecture notes before the class. The lecture notes will be available after only the class has been taken, Dr. Lasantha. So in the software, when a class is to be done, then you will only get the class notes and the class recording after the class has been taken. How much time we need for preparation? So Dr. Devanti, it depends totally upon you. If you have some job, if you have some family responsibilities, then take approximately 8 to 9 months. But this exam, if you're not in any engagement and you're not having any other responsibility, then with the job, even it can be done in 6 months. It's not a difficult exam. It's just that you need to be very well prepared for it. And you need a sound clinical knowledge to pass the exams along with the theoretical knowledge. And that can be done only by revising the stuff that we teach here. And this course pretty much covers everything in the AMC exam. There are some things which are not covered by Dr. Arshan, but will be covered by Dr. Mukaddas and me, because there are some topics which are not being discussed in the class, but as they come in the recall questions, they will be discussed by us. So in this way, we pretty much cover all the bases for your exam in order for you to pass the exams with a well-equipped knowledge. I don't believe in this myth at all, Dr. Zamalmi, that July is better or June is better. If you're well prepared, any month is better to pass the exam. You just need to know yourself that are you ready to take the exam? If you are, then it doesn't matter which month you're going to sit the exam. Okay? Yes, it's extremely possible. Vivo, whatever, doctor with the Vivo, it's possible to give the exam provided that you put all of your energy in getting the sound theoretical knowledge required to pass the exam. And if you're talking about October, so this is May, June, July, August, September, you still have like 5 months. Last 2 cardiac lecture is sufficient for exam. Look, the lectures are there for your basis. You have to have a regular review of the recalls as well. If you're not doing the recalls, it becomes very difficult for you guys to actually attempt the questions because you're not oriented for that. So not only the lectures, the recall sessions are very important. What kind of special care, Dr. Momita? The care we can provide you is guidance, counseling, and encouragement. That's it. And the rest is to be done by you guys. All right. So let's start the class today. I hope I have given you guys a review of what the course is about, how the course is to be taken, what is the role of me and Dr. Mukaddas, and how we can equip you guys with how to solve the recalls, because you have only 150 minutes to do 150 questions. And if you are very thorough in going through the recalls, you guys will be having like spinal reflexes of picking the points and solving the questions under less than 1 minute. All right. Okay. So whenever there is a recall, always try to pick up the important knowledge. So 17-year-old girl comes for contraception as she recently started being sexually active. Her BMI is 31. What opportunistic screening can be done for this patient? Option A, diabetes. Option B, eating disorder. Option C, pap smear. Option D, breast cancer.
All right. So important information. It's a 17-year-old girl with a BMI of 31. Recently sexually active. Now they're asking you about the opportunistic screening. What is meant by opportunistic screening? Can anyone tell me? Can anyone tell me what is meant by opportunistic screening? It's the kind of screening that you do whenever you have the chance to do it for that particular person. All right? Yes, very good. It is the kind of screening that is done when the opportunity provides itself. Very good. Dr. Mumeta has very simplified it. As the patient comes to us, then try to do it if it has not been done. So this is a 17-year-old girl coming for contraception with a BMI of 31. The opportunistic screening that you would preferably do in a patient who is recently sexually active would be a sexually transmitted infection screening, right? But that is not the answer here. Her BMI is 31. She is in obesity criteria. So with the obesity, do we screen for any eating disorder? No, unless they have given us some clue that the patient is having behavioral symptoms of bulimia or anorexia nervosa. Then we screen for eating disorder. We never screen for eating disorder unless the patient is having bulimia nervosa, anorexia nervosa, or overeating symptoms. She is coming with the obesity and being sexually active right now. Usually in Australian health system, pap smear is an old term. It's not used nowadays. Cervical screening test. Cervical screening test is usually done in patients who are 25 years and more of age. But if a person becomes sexually active less than 25, then from the time she becomes sexually active till 25 years of age, she can have a cervical screening test once. So that is not a good test to do right now. We can do it later on, right? And breast cancer screening is not required in this patient. They haven't mentioned any risk factors for that. So the risk factor for diabetes is obesity. So the thing that we need to rule out is whether she's pre-diabetic or not. Because if she is going into pre-diabetic or diabetic category, we can start counseling her and starting her on lifestyle modification that can help her to prevent the chronic disease development. Because once diabetes is developed, it's not reversible. It will be there always, and she has to have lifestyle modification in order to control it. Is everyone clear on this? All right. Now this is the RSAGP guideline regarding the overweight and obesity screening. So RSAGP is Royal Australian College of General Physicians. So if we want to study about the chronic diseases, this is one of the best guidelines to follow. All right, so all people aged more than 18 or less than 18, we need to assess their BMI first, whether they are obese or not. So when we have categorized whether the patient is obese or not, the next thing we do is check their cardiovascular, diabetes, and kidney disease risk. Because obesity leads to increased cardiovascular diseases, diabetes, and ultimately diabetes and high blood pressure leads to kidney disease risk. So this is the opportunistic part of the annual health checkup that we do in adults with overweight or obesity. Okay. You guys can have a go through regarding what we do in children with overweight and obesity, and what are the chemoprophylaxis that we can do once they are diagnosed as an obese case, and how do we manage them. So a lot of things for you guys to study from here. surgical options, environmental options that can help them, and then classification of the obesity, and the dietary guidelines for Australian adults to prevent or overcome the obesity and overweight in their lives. All of these guidelines are here. Okay? All right. Any question, guys? If there is an option for cervical screening, yes, if there is an option for cervical screening, then I would recommend that go for diabetes, because cervical screening test less than 25 years can be done anytime from the first time she had sexual activity till the age of 25. It's not a thing that you have to do like right now, right? If option for chlamydia, if they haven't mentioned about the BMI, then go for STI screening. All right. STI screening should be the first choice of answer if they haven't mentioned anything about their BMI and they said that she has recently started her sexual activity, coming to you for contraception. What is the opportunistic screening that you would do for her? So STI screening would be your answer there. Most common screening which is done in Australia is the STI screening, and you need to counsel her regarding that as well before you give her contraception. All right. Next question. A young patient came with hemothorax after trauma. Chest was intubated and 1800 ml of blood was drained. We replaced it with 2 liters of crystalloid. What will we do next? Thoracotomy, chest intubation, CT chest, pulmonary angiography, or blood transfusion? Okay, so this is emergency medicine. Emergency medicine, always remember, never go for procedure unless it is life-saving, okay? So A, C, A, B, C, D, E, all right? So can anyone tell me what is this mnemonic that we follow? Can anyone tell me what the C stands for in the ABCDE protocol? CABCDE protocol. This is a revised one in recent, I think it was revised in 2021, I guess. So C, A, B, C, D, E. So C stands for circumstantial hemorrhage, meaning a lot of hemorrhage. So 1800 ml of blood is a lot of hemorrhage. Hemothorax is a hemorrhage. A stands for airway, B for breathing, C for circulation, D for disability, and E for exposure. So hemorrhage in a trauma setting is coming before airway. If the person is bleeding, stop the bleeding before you go towards the airway, breathing, and circulation, okay? So this person has CABCD. This is the revised trauma protocol, which is now followed in Australian health system. Circumstantial hemorrhage should be controlled first, then check the airway, breathing, circulation, disability, and exposure. If this question was like a young patient came with chest trauma on X-ray, you have seen there is a hemothorax. What is the next step to do? In that way, airway, breathing, circulation would not be followed. circumstantial hemorrhage, airway, breathing, circulation should be followed. And the first thing you should do is the chest intubation in that patient before you make sure that the airway is intact, breathing is symmetrical, or circulation or patient is not going into hypotensive shock. Before that, you need to control the bleeding. That is the rule which is followed nowadays. So this has been already done, and 1800 ml of blood is in the chest. After the intubation of the chest, 1800 ml of the blood has been drained, and you have replaced just 2 liters of the crystalloid. What is the next life-saving thing that you need to do? Thoracotomy, chest intubation, CT chest, pulmonary angiography, or blood transfusion? What is the life-saving thing that you need to do in this patient before you move him to theater? Very good. We need to transfuse blood in this patient, guys, before we go for thoracotomy. Blood transfusion can be ongoing during the thoracotomy. And then you can find out the source of bleeding by open thoracotomy and stop that. Okay. Even though you have given crystalloid, patient has lost blood. You need to be giving blood products immediately to this patient. 1800 ml of blood is a large amount of blood. He will be going into hypotensive shock if you're not transfusing blood to the patient, and not going to survive the surgery unless you are replacing that which is lost by the patient. Okay. Now, sometimes they give you, this is not in the option. Then what would be the next step? Well done, Dr. Hadis. So next step will be life-saving procedure. So life-saving procedure is thoracotomy. We don't need to waste time for CT chest or pulmonary angiography in a bleeding patient. CT chest is not going to tell you about where the blood is coming from. It's just going to tell you where the blood is being collected, right? So you need to go for open thoracotomy to stop the bleeding in the chest. All right. Okay. So the first step is chest intubation. Yes. In hemothorax, the first step is chest intubation. You won't know how much blood is lost before you replace it, right? So chest intubation, how much blood is coming into the chest, accordingly give crystalloid or blood transfusion. All right. So this is the guideline for the blunt chest trauma. And I think it is Queensland Health. Yep, Queensland Health one. So it has all the chest traumas that you need to study for your exam. We just need to go for, so ATLS guideline. Okay, this is just for the admission. Okay. Primary survey, secondary survey, tertiary survey, very, very important for the ATLS. Principal diagnostic imaging is a chest X-ray, CT scan, that's it. Or sometimes we can do a EFAST that can help to identify free fluid present in the chest or in the abdomen. EFAST is done in the abdomen as well. Pathology that you can do is complete blood count, Chem20, VBGs, blood group, and whole coagulation studies. Management, hemothorax. All hemothorax should be considered for drainage regardless of the size. Drainage should be done through a large bore intercostal catheter. Small ones can be managed without drainage initially in a stable patient with a repeat of the X-ray to monitor the progression. but all of them require drainage. What happens with the massive one? Massive hemothorax, a rapid blood loss greater than 1500 into the chest cavity causes impairment of the ventilation and oxygenation, along with the hypotension and shock. And immediate chest decompression and restoration of the blood volume are vital. So chest tube intubation for drainage along with the restoration of the blood volume. These are the two main important steps that you need to do in a patient with the massive hemothorax. A chest tube can assist. However, a thoracotomy may be indicated in case of the large or still ongoing blood loss. I hope it answers the question. Clear, guys? So two important parts in the hemothorax is that you need to put a chest tube for drainage, and then you need to replace the volume lost by the body. The third one is that if the patient is still having ongoing blood loss, or if the hemorrhage is more than 1500 ml, you need to go for open thoracotomy. Is it clear, guys? Any question? Okay. Can you briefly explain CABCD? So C, circumstantial hemorrhage. Then A, B, C, D, E is the same as the previous one. Airway, breathing, circulation, disability, and exposure. C, A, B, C, D. Circumstantial hemorrhage, airway, breathing, circulation, disability, and exposure. All right. Cool. Next question. No worries. This is how I usually do in my recall class as well. I ask multiple times any queries, and if you have queries, we discuss that before moving on to the next question, okay? All right, so this is the picture that I have given you. It's an external hemorrhoid. How will you manage the best way for this hemorrhoid? Band ligation, hemorrhoidal artery ligation, cryotherapy, or hemorrhoidectomy? So always pay attention to what they're asking. They're not asking you about the initial management. They're asking you about the best way to deal with this. So a best way to deal with the external hemorrhoids is hemorrhoidectomy. Very good, guys. Band ligation is the initial step for which type of hemorrhoid? Is it for the external hemorrhoid or internal hemorrhoid? Can anyone tell me? Internal, very good. So band ligation is initially we do for internal hemorrhoids. It can be done by a GP as well if they are trained for it. Otherwise, it can be done in the OPD of the surgery. Cryotherapy can also be done in the OPD surgery, but this is a second line treatment for the internal or external hemorrhoid. And then the best for both of them is hemorrhoidectomy. But for the external, the best one is still external lateral hemorrhoidectomy, because band ligation is not going to work here. Cryotherapy is very painful and it doesn't help that much with the external hemorrhoids. And once the external hemorrhoid becomes thrombosed, the best way is to just decompress it and do a hemorrhoidectomy. All right. So a couple of guidelines are there. So let's go through the RSCGP article first. Initial is the sits, bath, and dietary modification. The same for the internal and external. The first one is the lifestyle modification, sits, bath, stool softener, and internal hemorrhoid pharmacological management starts with the band ligation, cryotherapy, then hemorrhoidectomy. For external, Cryotherapy is not so much used, but hemorrhoidectomy is a good option to go for. Can you guys see the screen for this article? So we know that hemorrhoids, internal and external. Internal are the one above the dentate line and external are the one below the dentate line. Internal are usually painless and external are usually painful. And it's most commonly caused by straining, constipation. If you're having varicose of the area, especially during pregnancy. What else? So there are degrees of it. The first degree is that it causes bleeding, but it stops on its own. Second degree is that the lump itself comes down, but goes away, and the patient has defecated on its own. Third degree requires manual reduction. Fourth degree does not reduce anyway. All right. So thrush or itching is associated with the internal hemorrhoids. Fissures are very common with it. Strangulated hemorrhoids are very common in external hemorrhoids. Skin tags are very common. Prolapse can be associated, and perianal hematoma is also associated with the external hemorrhoids. History will that patient will give you that I'm bleeding and there is a lump coming and there is pain if it is external or painless if it is internal. But if the patient is giving you history that the blood is mixed with the stool, alternative constipation, diarrhea, weight loss, then don't think just about the hemorrhoids. Search for some insidious cause like the colorectal cancer. And bleeding in the hemorrhoids is bright red and it's separate from the feces, either on the toilet paper or on the feces. Prolapse can also happen. Discharge and irritation, very common with the hemorrhoids. Incomplete bowel evacuation can happen, anal pain. Constipation or diarrhea is not very commonly associated with hemorrhoids. So constipation is most commonly associated. External hemorrhoids, the ones below the dentate line, painful, skin tags and polyps are associated with them. Perianal hematoma is an external hemorrhoid that has become strangulated. So they are very, very painful and needs to be treated within the first 48 hours. And it requires drainage of the hematoma. Examination, you can do perianal region examination after the consent of the patient in the presence of a chaperone. You can inspect for any skin tag, any anal fissure, any thrush present, scratch marks. Then you have to do a DRE examination. And then we can, in the hospital, you can do a proctoscopic examination. But if in a surgical OPD, they can sometimes do a rigid sigmoidoscopy and barium enema as well. Colonoscopy is not usually performed for the hemorrhoids. It's usually with the proctoscopy, the hemorrhoids, even the internal ones are visible. Sorry. Treatment of the hemorrhoids. So the first one is that you need to do the lifestyle modification for the treatment of the hemorrhoids. Stool softeners if the patient is having constipation, and lifestyle modification with the diet. If the patient is having painful hemorrhoids, you can give topical anesthetics and analgesics, or you can give vasoconstrictors, which is rectal jizz. You can give that to the patient or ask the patient to do sitz bath. It helps a lot in healing a painful hemorrhoid as well. Hemorrhoidectomy. This has largely replaced other procedures because sometimes band ligation cryotherapy doesn't work for some patients, and hemorrhoidectomy is now being done largely for internal and external hemorrhoids, but mostly for external hemorrhoids. Rubber band ligation, it's for internal hemorrhoids. First pharmacological surgical management that we do for it. Injection is the second one. sclerotherapy, you can give an injection of the phenol inside the hemorrhoid and it can cause them to shrink and cease bleeding. Laser hemorrhoidectomy for grade 3 and 4, and staple hemorrhoidectomy again for grade 3 and 4. Okay, what else? That's it. Any question, guys? You can also study it from Mayo Clinic, but I think the RSCGP is enough for your exam and it has sufficient information. Because this exam is not like a specialization exam. It's an entrance exam and it requires the knowledge of a junior medical officer. Basically, they are going to ask you questions of the level of the junior medical officer, never above it, never ever above it. All right. This one. Next question. A 65-year-old patient presented to GP clinic with the complaints of pain and difficulty in the use of the proximal muscles of the body. He's complaining of subjective fevers, malaise, lethargy, and on blood test, ESR is raised. Which of the following is the treatment of choice for this patient? Option A, paracetamol. Option B, prednisolone. Option C, methotrexate. Option D, IVIG. All right, so majority have answered prednisolone. Can anyone tell me what is the diagnosis over here? Weak pain and difficulty of the proximal muscles with the inflammatory marker raised. Very good, Dr. Noshin. Very good, Dr. Arpita. This is polymyalgia rheumatica. It's a very vague one. But the thing that is most going with polymyalgia rheumatica is the proximal muscle involvement, the fever, malaise, lethargy with ESR raised. So this is typical for polymyalgia rheumatica features. All right, and the treatment for polymyalgia rheumatica is not paracetamol. It's prednisolone. We don't give methotrexate for polymyalgia rheumatica, nor do we give IVIG. All right, so the best way to treat it is by giving steroids. All right. All right, can anyone tell me, there is another question that comes in the exam, very, very common, because this is the favorite topic of AMC. Polymyalgia rheumatica. So there is a disease associated with polymyalgia rheumatica, which is a medical emergency. Can anyone tell me the name of the disease? There is a disease associated with polymyalgia rheumatica. Very good. Arthritis. Giant cell arthritis is a combination of that disease with polymyalgia rheumatica. That disease is known as temporal arthritis. So patient will present with painful throbbing in the temporal region, fever, malaise, lethargy, jaw claudication, sensitivity of the scalp, and if this patient is already diagnosed with polymyalgia rheumatica and they are coming with these features, if you have not started the patient on IV prednisolone, this patient is going to have permanent vision loss. So unilateral blindness happens in temporal arthritis. So your patient of polymyalgia rheumatica should have annual eye checkups. Otherwise, if the patient has acute symptoms of the temporal arthritis and you have not given the sufficient amount of steroids required, this patient can permanently lose the eyesight in that area. All right. IV. We don't give oral for TA. It's IV. It's an emergency. It's a medical emergency TA. So the diagnosis of TA is initially with the blood test. ESR is raised. But for diagnostic test, it's the biopsy of the temporal artery. We usually don't do the temporal artery biopsy. We just stick with the ESR. It's better to give IV pred in a patient than to have them blind. So even though if the patient is not having TA in a polymyalgia rheumatica patient, don't let it stop you from giving the IV for high clinical suspicion of TA. Okay? That's the cardinal rule. Don't stop yourself from giving IV pred because it's not going to do any damage if the patient is not having TA, but if it's going to do a lot of damage if the patient is having TA. So if PMR patient on pred comes with TA symptoms, yes, so we will start IV. Sure, that's what we do. If the patient of polymyalgia rheumatica is on oral prednisolone, is coming to the GP clinic with like my head is hurting, I'm having this jaw claudication, and it feels like the vision is affected, you need to send the patient to the emergency department for IV methylprednisolone. Initially, we do ESR, but the diagnosis is confirmed by the temporal artery biopsy. Yes. All right, so this is the RACGP information for polymyalgia rheumatica. It's inflammatory rheumatic disease. Clinical features. So hallmark of the polymyalgia rheumatica is the proximal muscle stiffness and pain. So proximal muscle groups include shoulder and hip girdle. Stiffness may be so profound that the patient has difficulty turning over in the bed, rising from a bed or a chair, or raising their arms above the shoulder height, for example, to comb their hair. These are the symptoms they will give you in the exam in the scenario. All right, what else? So the new diagnostic criteria has been developed. So try to look at this area, not this one. Age should be more than 50 with new onset of bilateral shoulder pain or bilateral hip pain. Okay. New hip involvement, such as pain, tenderness, and limited movement, it will be bilateral. Morning stiffness, more than 45 minutes, elevated ESR or CRP. In the absence of positive rheumatoid arthritis serology. So whenever there's a bilateral involvement of the shoulder or hip joints, we usually think of rheumatoid arthritis first, and we do RA factor, anti-CCP antibodies, stuff like that. So if your antibodies for the RA is negative, think about PMR. And you send the patient for ultrasound, and the ultrasound shows the findings consistent with polymyalgia rheumatica, which is subacromial bursitis, bicipital tenosynovitis, glenohumeral effusion, or abnormalities in the hip, like the same ones. There will be inflammation and infusion. So you think about polymyalgia rheumatica. So in the rheumatoid arthritis, patient will usually come with the joint involvement of the small joints of hand and feet first, bilaterally, not the large joints. Ankylosing spondylitis, patient will be very young and coming with the low back pain and stiffness in the morning. This is a rare disorder. No need to. SLE will be very typical. Coming with the rash, coming with the bilateral joint involvement, coming with the photosensitivity, mouth ulcers. So it will be there. So Jordan syndrome, dryness of the eyes, dryness of the mouth, joint involvement. The one which is very similar to polymyalgia rheumatica is dermatomyositis or polymyositis. So in polymyalgia rheumatica, there will be bilateral muscle stiffness and pain. Whereas in polymyositis, there will be rash on the back of the hands, on the face, and there will be weakness of the muscles instead of pain and stiffness. And in polymyalgia rheumatica, the inflammatory markers are raised, whereas in polymyositis, CK will be raised, creatine kinase, because this is the inflammation of the muscles. Non-inflammatory disorders you don't need to know about. You need to refer the patient to the rheumatologist. Giant cell arthritis should also always be considered in a patient with the polymyalgia rheumatica. A thorough clinical evaluation, which is the eye examination and the jaw examination, should be done. You should also do the ESR, but temporal artery biopsy is not required, always not required. And if you're suspecting, start high-dose corticosteroid therapy or send the patient to the emergency if he's complaining of vision problems. You need to start IV prednisolone in this patient. So symptoms such as temporal artery tenderness, unilateral headache, jaw and tongue claudication, visual loss. These are the symptoms of temporal artery arthritis. All right. Investigations we have already covered. Pharmacotherapy, we need to give corticosteroids. What else? So if you're suspecting a patient coming with a headache, then the corticosteroid you need to start is 40 to 60 milligram and continue for 4 weeks. But if the patient is coming with vision problems, IV methylprednisolone. Don't forget, guys. For PMR, you need to give maintenance therapy. If the patient is getting better, you can reduce 1 milligram every 4 to 6 weeks, okay? What else? Because this patient can get side effects of the steroid, so give complement therapy with calcium and vitamin D. Assess the patient's bone mineral density and T-scores to see if they are developing osteoporosis or not. All right. Any question? No, you don't have to remember doses. It's just for your information. Just remember that whenever there's GCS, you have to start with the highest doses. If it is PMR, just normal prednisolone dose. No worries. No, IV treatment is just given for 24 to 48 hours so that the vision symptoms resolve. It's not given for 4 to 6 weeks. IV is just for 24 to 48 hours, and then we taper it off with the oral one. No worries. Okay. Next question. I hope you guys are not tired. Do let me know. We will take a 5 to 10 minutes break, okay? All right. Next question. A 14-week pregnant female came with the lower urinary tract infection symptoms. Urine analysis and culture showed that it was a group B Streptococcus UTI, which was treated appropriately in the patient. When will you again check the vaginal colonization for GBS in this patient? 34 to 37 weeks, 18 to 20 weeks, 24 to 26 weeks, week 30th. So can anyone tell me the significance of doing screening for GBS in a patient who is pregnant? Why do we do it? If the patient is having GBS at 34 to 37 weeks, then what is the significance of it? Why do we do it? Chorioamnionitis, very good. Meningitis in neonatal sepsis. All of you are correct. How do we prevent that from happening? Very good. We give IV antibiotic prophylaxis in labor, 4 hours into the labor before the patient's water breaks, so that the baby does not develop neonatal sepsis or have colonization of the GBS into the baby system. Very good. Excellent. So we usually do it around 34 to 36 weeks. The GBS swabbing, we do it around 36 weeks, okay? All right, for obs and gynae, I say SA health, but for GBS one, this is the best one that I have found. It's very well written. So group B, streptococcal disease in the pregnancy. So it's a common bacteria, which is usually normally found in the vaginal tract of the patient. All right, but the thing is, if it is found above a certain amount, it causes asymptomatic or symptomatic bacteriuria. And if it is in a pregnant female, it can be transmitted to the baby during the labor if it is through vagina. That is why we do give prophylaxis at that time as well, Dr. Saman. If the patient is coming with a premature rupture of membranes, we start the IV antibiotics if we know that she is GBS positive. All right. Where was I? Approximately 20 to 24% of the Australian women will be colonized with GBS and may be passed from mother to baby during labor and cause neonatal early onset GBS infection in the first week, which is basically neonatal sepsis. In the absence of antibiotic prophylaxis, babies will develop early sepsis, neonatal pneumonia, and meningitis. So neonatal sepsis occurs in the form of pneumonia and meningitis. So the intrapartum prophylaxis with antibiotics reduces this risk by 86 to 89%. So that's a lot of reduction. That is why it's a screening that is done in these patients. So risk factors is in the babies is that neonate with early or late onset disease, a positive culture for the mother in the current pregnancy, having a UTI during the current pregnancy, you have made a clinical diagnosis of chorioamnionitis, and a twin is born with early onset of the GBS syndrome. Okay, so whenever there is no screening, but a patient is coming with premature labor of less than 37 weeks, rupture of membrane is more than 18 hours, not followed by the labor, or patient is having intrapartum fever, we still start the IV antibiotics during the pregnancy. So we do the screening usually, and what we do is the first screening is done, yes, benzyl penicillin or amoxicillin, both are great. What we do is that on the first visit, we do a urine analysis and culture. And then we do it, if the patient is positive, then we regularly do it unless patient is negative, and then we do the screening for the GBS at 36 weeks. So 35 to 37 weeks or 3 to 5 weeks prior to the birth in a high-risk pregnancy, such as poorly controlled diabetes or multiple pregnancy. Doesn't matter if a mother who is positive with GBS in the current pregnancy, woman was positive with GBS in previous pregnancy, we have to, or patient is having asymptomatic bacteriuria with GBS in the current pregnancy or previous pregnancy, we have to give them IV antibiotics during the labor. But females who had a previous baby with GBS does not require this screening to be done in the current pregnancy. We don't want to repeat because we are going to give them IV antibiotics regardless of the results. Okay, so swab should be taken from the high vaginal area and the rectal area. So 4 hours prior to the birth, we usually give amoxicillin, cefazolin. What else? So when we give antibiotic prophylaxis, a positive culture, a child previously born with the infection, symptomatic or asymptomatic bacteriuria of GBS in any part of the current pregnancy. And if a patient is coming with unknown cultures and unknown screenings and risk factors are there, we do not give in the cesarean because the patient is not going to pass through the vaginal canal. So benzyl penicillin, allergic to benzyl penicillin, you can give cefazolin. Who are having allergy to penicillin, cephalosporins, you can give clindamycin or vancomycin if it's a resistant strain. What else? In case of HSV, what can we do? In females or in the baby? If the patient is having active lesions, we go for cesarean section. Yes, that is true. Yes, Dr. Hadis, you're absolutely right. If the patient is having active lesions, we go for cesarean section. We let the mother know that the risk of baby contracting the disease is really, really high. Okay. Next question. A 71-year-old lady presented for the first time in 5 years to the GP clinic for annual review of the health. What will you do of the following in this patient? Cervical screening, mammography, OPT, or CT scan of the lung? So this is a bit of a tricky question. 71-year-old lady presenting after 5 years to a GP clinic for an annual review. So we don't need to do a FOBT and CT scan because she is not having the risk factors. FOBT is only done in the risk categories, right? So mammography and cervical screening is done up to 74 years of age, right? But cervical screening is more required in the reproductive age group because cervical cancer is more common in the sexually active females. So in this patient, I would do mammography instead of doing the cervical screening test. Okay? Because breast cancer more common in the postmenopausal females, cervical cancer more common in the sexually active menstruating females. But both screenings are done till 74. Are you getting why I chose mammography? We have to weigh the risk factors in this case. Cervical screening is done in the reproductive age group more because of the sexually active females contracting cervical cancer by human papillomavirus, right? It's less common in the elderly. Cervical cancer, very, very less common in the elderly, especially in the postmenopausal females who are not sexually active. If they're sexually active, sure, you can do the screening up to 74 years of age. If not, it's not necessary. If their cervical screening test after 69 or before even 69, they are continuously negative, then you don't need to do it after 69 years of age. But mammography, it's required more in the postmenopausal age because the breast cancer is very common in the postmenopausal age group. FOBT is done for the low risk group. Yes, Dr. Kubra. And the low risk is that one of the family members is having colorectal cancer of age more than 55 years, or a second-degree relative having colorectal cancer of age more than 55 years. Even the low risk category has a first degree or a second degree relative with a colorectal cancer diagnosed in them. If the question mentioned women sexually active, no, then obviously the answer would be cervical screening. Though both answers are correct because we do cervical screening and mammography up till 74. But cervical screening is more in patients who are sexually active and in their reproductive age because they contract cervical cancers in that age group. But in postmenopausal females, the most common cancer is breast cancer, not cervical cancer. Is it clear, guys? If you just study this, I think it will help. So the United States Preventive Services Task Force recommend the average risk of cancer. So colorectal cancer can happen up to this age, very common. Breast cancer screening, 74. Cervical cancer screening through age 65, okay? Because as I said before, cervical cancer, not very common in the postmenopausal females. Breast cancer, more common. Colorectal cancer, more common. But for colorectal cancer screening, you need to have a low risk assessment as well, either first degree or second degree relative with a specific age group having colorectal cancer diagnosed in them. Okay, next question. This is an interesting question. I hope you will. It's like a math equation. Elderly man with the hearing aids and bilateral cerumen impaction, which is basically wax. He's having bilateral Riney test positive and Weber test is lateralized to the right ear. What is the diagnosis? Conductive hearing loss in the right ear, sensorineural hearing loss in the right ear, bilateral acoustic neuroma, or otosclerosis. So math equation. Okay. When Riney is positive, what does it mean? Can anyone tell me? Air conduction is more than bone conduction, right? So in a cerumen impaction, bilateral Riney test is positive, meaning air conduction is more than bone conduction. But Weber is lateralized to the right ear with the cerumen impaction. So when a conductive hearing loss, Riney is positive in conductive hearing loss, right? When there is conductive hearing loss and the Weber is lateralized to the right ear, this means that conductive hearing loss is happening more in the right ear and sensory neural hearing loss will be in the left ear. Weber lateralizes to the normal ear in sensory neural hearing loss, but to the affected ear in the conductive hearing loss. So this is conductive hearing loss to the right. Let me show you guys. Where is the... So we do a Weber test by putting the tuning fork in the middle of the forehead. All right. And it should be equal on cerumen impaction means wax impaction. So it should be equal in both ears in a normal person. But when there is sensory neural hearing loss, the sound will be transmitted more in the normal ear. So if the person is having sensory yes, you're right, Dr. Kubra. So this should be sensorineural hearing loss in the right ear. No, the question is wrong. Bilateral, negative. Otherwise, it will be the question will be wrong. If there is a cerumen impaction, the conduction, there should be conduction, bilateral conductive hearing loss. And if it is lateralized to the right ear, conductive hearing loss should be on the right side more, and sensorineural hearing loss to the left side. All right. Yes, the answer should be the sensorineural hearing loss in the left ear. Then it would be right. So this is if it is negative. If bone conduction is more than air conduction, Riney is bilaterally negative. Weber lateralizes to the affected ear more in the conductive hearing loss. It should be lateralizing to the normal one in the sensorineural, which would be sensorineural in the left side. Okay, listen to this, guys, first. Sensorineural hearing deafness, the sound is transmitted more to the normal ear. So if there is conductive hearing loss bilaterally with the Riney negative, the Weber should be lateralized to the left ear in the sensorineural hearing loss. Whereas in the conductive deafness, it is heard better in the normal ear. Are you guys getting what I'm trying to say? No, okay, all right. So conductive hearing loss happens when the conduction of the air from the entrance of the ear is blocked to the tympanic membrane, right? So this is ear canal, and this is the tympanic membrane. Anything that hurdles the ear canal from the entrance of the air sounds to the tympanic membrane causes conductive hearing loss, okay? And in conductive hearing loss, Riney is negative. Bone conduction more than air conduction. Okay? Get it? So you're having cerumen or wax infection here. When a Riney is negative bilaterally, it means that bilaterally there is conductive hearing loss. Then you do a Weber test. Then in conductive hearing loss, the Weber test will be lateralized better in the abnormal ear. You will hear the sound better in an ear with more wax in it. Whereas if the person is having sensorineural hearing loss, the sound would be transmitted more to the normal ear. Okay? So our person is having bilateral Riney, but the Weber is lateralized to the right ear. It means that conductive hearing loss is more on the right ear, and sensorineural hearing loss should be present on the left side if it happens, not on the right side. Okay? The normal ear should be having sensorineural hearing loss, less conductive hearing loss. But if conductive hearing loss is present on the right side with the Weber lateralizing to the abnormal ear, it means the wax is more impacted on the right side as compared to left. And sensorineural hearing loss, Weber should go towards the normal ear, not towards the abnormal ear. Oh, I'm glad it is clear. Okay. So this is the interpretation of the test. Normal, Riney is normal when air conduction is more than bone conduction in both ears. And Weber is normal when the sound is going to both ears normally. Hearing aid is presbycusis, which means it's a mixed one. Presbycusis is a mixed one. Sensorineural hearing loss along with the conductive hearing loss. It's old age hearing loss. All right. So in conductive hearing loss, Riney will be negative, which means bone conduction will be more than air conduction in the affected ear. and Weber will lateralize to the affected ear. Sensorineural hearing loss, Rhine will be positive in the both ear, but Weber test will be lateralizing away from the affected ear. Mixed hearing loss, you will have Rhine negative in the affected ear and positive in the unaffected ear, whereas Weber will lateralize to the unaffected ear away from the affected ear. I hope this makes it easy for you guys to understand. All right. Okay. Next question. We are moving a bit slow. I have more than 60 to discuss with you guys today. So let's pick up a pace a bit. There is an old patient who is having neck of the femur fracture. How will you guide the nurse to prevent pressure sores in the hospital? A, use air mattress. B, change posture to lateral sides 2 hourly, or leg physiotherapy. So this is to prevent the pressure sores. How would you ask the nurse to prevent it? Very good. So we will ask the nurse to change the posture to lateral sides every 2 hourly. All right. Air mattress can be used, but it's not all. It's in the ICU setting. This patient is just having a neck of femur fracture. Ultimately will be mobilized. Till they are mobilized, change the posture to lateral sides every 2 hourly. So if you go the preventing of the pressure sores in the hospital, there are a bunch of things they have mentioned in the Better Health Victoria. So skincare in the hospital. Keep the skin clean and dry. Avoid any products that dry out the skin, such as soaps, body washes, talcum powder. Use a water-based moisturizer. Check your skin every day and ask for help if you're concerned or if you see any redness, swelling, or sore. If you're at risk of pressure sore, a nurse will change your position often, including during the night. Always use any devices given to you to protect your skin from tearing and pressure sores. That includes protective mattresses. So this comes on second line. First one is always changing the position. Before that, not using anything that dries out your skin more. So first of all, you will be changing the position. Second one is that you may use any device like air mattresses, seat cushion, heel wedges, and limb protectors. Hydrate yourself. Maintain your nutrition. Maintain the toilet routine. If you have a wound, a plan will be developed by the multidisciplinary team for the care of that area. Okay. Most commonly, the pressure areas are hip, knees, tailbone, and heels. Next question. Any question, guys? That was a pretty easy one. All right. There is a polytrauma patient with bladder distended on palpation. You noticed blood in the urethra. How will you proceed with the catheterization? Suprapubic catheterization, past urethral catheterization, or PCN? Very easy question again, very commonly asked and very commonly dealt with emergency as well. If a patient is coming to you after trauma to the pelvis or to the genital areas and you notice there's a blood in the urethra, always assume the patient is having urethral injury. Do not go for the catheterization. All right, do not insert a urinary catheter through the urethra. Percutaneous nephrostomy. It's not done for the bladder. All right, always go for the bladder scan. If the patient is having a distended bladder, then you go for suprapubic catheterization, and it is always done by a urologist or a specialist in the emergency who is trained with it. Otherwise, you just wait. and give some pain relief to the patient before the patient can void, okay? All right. This is the urology health guideline regarding the trauma. So urethral trauma, if the urethra is injured during any cause, so what will be the symptoms? Swelling, inflammation, infection, pain in the belly. Other signs will be the patient is not able to pass the urine, bladder is being filled up with the urine, and there is blood in the urine or blood at the urethra. For males, the most common sign of the urethral injury is that blood, even a drop of it at the tip of the penis. Swelling and bruising of the penis, scrotum, perineum may also occur along with pain in that area. Causes, trauma is the major cause of the urethral injuries. Diagnosis, if you have blood at the end of the penis or the urethra or in the urine, can't pass pee, this is a high clinical suspicion of the urethral injury. Your healthcare provider may try to pass, but not being able to pass is the first sign. X-ray can be done, ultrasound can be done, that can help to assess whether there is injury to the urethra or not. Treatment depends upon whether we require surgical treatment or not. If urethra has completely torn away, urine must be drained. This is done with the tubes snuck into the bladder through the skin, which is suprapubic. Foley's catheter goes through the skin just above the pubic bone into the lower belly of the bladder. This is most common after severe injuries, okay? What else? After the surgery is done, the catheter is left in the bladder. They usually take out the suprapubic catheterization after the repair of the urethra and try to pass it into the urethra to see if the urethra is patent, or they ask the patient to void themselves. If the patient can void, then no need to pass the urinary catheter through the urethra. Clear, everyone? Okay. Next question. A patient presented to emergency with agraphia, acalculia, inability to tell left from right side. Which of the following regions he is having a compromise of the arterial supply? Cerebellar vermix, left parietal, frontal lobe, or occipital lobe stroke? So language, memory, and spatial orientation is done by the left parietal lobe. Very good, guys. So this is very important for your exam, the areas, which areas control what thing in the body, and if they have a stroke of it, which area is affected. So they will give you like this, like if the patient is having locomotion and mood problem, intelligence and judgment impaired, logical thinking is impaired, behavior and personality is impaired, planning and inhibition and memory is impaired, frontal lobe stroke. If the person is having speech and behavior problem, memory, emotions problem, vision and hearing problem, it's mostly a temporal lobe stroke. If it is a brainstem stroke, the problems will be in your vitals, which is blood pressure, breathing, heart rate, and swallowing. If the parietal lobe is affected, language and reading, coordination, sensation, intelligence and reasoning, and spatial orientation will be affected. Occipital lobe, vision, cerebellum, balance and coordination, and fine muscle control. Now, this one I have put here, it is according to the arterial supply. So if it is anterior cerebral artery, then movement and sensations on the opposite side of the body. If it is middle cerebral artery, so it is parietal lobe stroke, loss of movement and sensation, vision loss, impaired speech, awareness of the objects, and person's left side. If it is anterior choroid artery, then basal ganglia will be affected. Posterior cerebral artery, then vision will be affected. Midbrain, then cranial nerves, pons, cranial nerves, along with the swallowing, chewing, and speech. If it is medulla oblongata, cranial nerves, along with heart rate, breathing, and circulation. Okay, so you need to remember, you need to cram all of this and all of this, because they do ask a lot of it in the exam. This one, Dr. Hitu, this one. Okay. You can easily find them on Google if you're not able to take screenshots of today's lecture. Just type areas of the brain affected in a stroke or arteries affected in stroke, and these will come over there. I have also taken them from Google. All right, next question. Any queries, guys? So you need to revise the arteries which are affected and what kind of symptoms they're producing, and which areas of the brain are affected and which sort of symptoms are affected. These are very important for your exam, especially if it is coming in stroke. Okay, if they're asking questions from stroke, they will definitely ask you about the arteries. All right, next question. A diabetic foot ulcer of 1 centimeter, pus discharge, cellulitis, which is present till mid-shin. After irrigation and debridement, what will you do? IV antibiotic, MRI of the foot, oral amoxicillin, or X-ray? Okay, so majority are answering between A and D. So let me just open one of the things from RSCGP that can help. There's an acronym which is followed in RSCGP. I'm just going to copy that and paste it over here. Okay. So Matador. This is the sequence that we do in a foot ulcer management. So we optimize the hyperglycemia. We assess the diabetic foot and classify it according to the PEDS score, which is perfusion, extent of the ulcer, depth of the ulcer, infection, and sensation. So not only are we ruling out the diabetic foot ulcer along with cellulitis, we are also ruling out the peripheral artery disease. Then we do the debridement, then we do antibiotics. Then we do dressing, offloading, referral, education, and x-rays later on. After debridement and cleaning, we give antibiotics. So in this patient, do we give IV antibiotics or oral antibiotics? Why are we giving IV antibiotics? Can anyone justify their answers? That is not a justifiable answer. No, the practice is clinical judgment, but theoretically, if a patient is not having any systemic signs, we don't give IV antibiotics in a patient with diabetic foot ulcers. We give oral antibiotics, okay? So if they are not having any systemic signs, we don't give IV antibiotics. Look at this. Even if the patient is having cellulitis, we don't give. Okay, so this is the classification. No local signs of infection, uninfected. Infection present, local swelling, erythema between 2 centimeters around the ulcer, local tenderness or pain, local warmth or purulent discharge, it's a mild one. Local infection with erythema or cellulitis more than 2 centimeters around the ulcer or involving structure deeper than skin and subcutaneous tissue, and no systemic signs, then this is a moderate one. Our patient is having moderate infection. If there is any systemic sign like temperature, heart rate more than 90, respiratory rate is high, WBC count is high, then this is a severe infection and requires IV antibiotics. So in mild and moderate, we give oral antibiotics. In severe, we give IV antibiotics, okay? In the diabetic foot. That is not the practice. The practice is clinical judgment. But if the patient is not having any systemic signs, don't give IV antibiotics, okay? Is it clear, guys? So here, after debridement and drainage of the pus, we will give antibiotics followed by X-ray to see if there is any signs of osteomyelitis that might require MRI. Answer is C, yes. Yes, you have to memorize the antibiotics for the diabetic foot. It's most commonly flucloxacillin or cefazolin that we give. X-ray we do afterwards. No, MRI is not the first radiology that we do in a diabetic foot. We do X-ray. If the X-ray is showing signs of osteomyelitis, then we proceed for the MRI. Cool. Clear? Okay, this is an easy question. A female patient above 60 is presenting with pain in the first metacarpophalangeal joint and proximal interphalangeal joint. Which one of the following is responsible for this manifestation? Rheumatoid arthritis, osteoarthritis, idiopathic osteoarthritis, or gout? Sorry, the wording should be now. Pain bilaterally in the first metacarpophalangeal joint and proximal interphalangeal joint. What should be the answer? Very good. This is rheumatoid arthritis. In osteoarthritis, it will be unilateral and most commonly metacarpophalangeal joints and distal interphalangeal joints. Gout will also be unilateral and it involves mostly metacarpophalangeal joints, not the distal or proximal interphalangeal joints. So if you look over here, the metacarpophalangeal joints and the proximal interphalangeal joints, these are the deformities of the rheumatoid arthritis and proximal ones, right? In rheumatoid arthritis, bilaterally. In osteoarthritis, it's mostly the distal interphalangeal joints that are affected, and mostly it's unilateral. There will be cartilage loss, whereas inflamed synovium will be present in rheumatoid arthritis. Okay. Asymmetrical and symmetrical. Morning stiffness less than 30, morning stiffness more than 30. Stiffness gets worse with activity in osteoarthritis. Stiffness which gets better with activity is rheumatoid arthritis. Okay. An ECG shows atrial fibrillation with the rate of 130 beats per minute. Irregular rhythm. You calculated the Chadwick score and it's more than 2. What will you do next? Metoprolol, apixaban, or Loprin? Very good. So This question is quite confusing. Many people have answered with apixaban. Why we are not giving apixaban first? Because the rate has not been controlled yet. Atrial fibrillation is still having a 130 beats per minute. It's a higher rate atrial fibrillation. We need to control the rate first before we can start the anticoagulation therapy in the patient. So, sustained atrial fibrillation should be controlled with metoprolol before we do the Chadwick scoring for it. So how do we do it? This is the heart foundation. So if the patient is hemodynamically unstable and patient is having atrial fibrillation, then we do the cardioversion first, okay? DC cardioversion. And then we calculate the Chadwick score. If it is more than 2, oral anticoagulants long-term. 1, oral anticoagulants long-term. If it is 0, just for 4 weeks. If a patient is having atrial fibrillation with rapid ventricular response is usually with a higher rate, then we see whether patient with atrial fibrillation is having any signs of heart failure or not, or having any left ventricle diastolic systolic dysfunction. If there is no signs of heart failure, start with beta blockers, or if the beta blockers can't be given, give calcium channel blockers. If calcium channel blockers can't be given, you can add digoxin, but digoxin is the last resort. If there are clinical signs of heart failure, start with beta blockers and add digoxin, because we are not just treating the atrial fibrillation now, we are treating the heart failure as well. Okay, in terms of anticoagulant, which is better? So warfarin and apixaban, it depends upon patient to patient who can tolerate what. Apixaban is new oral anticoagulant, shorter duration, easier, doesn't require any reversal, while warfarin is an old one and requires monitoring continuous. So it depends upon patient to patient. All right, next question, and then we'll take a 5 minutes break. Any question for atrial fibrillation, guys? No? Okay. If Chadwick scores, yes, we still anticoagulate, but not long term. We anticoagulate for just 4 weeks. All right. Let's take a 5 minutes break, and then we'll be back and complete our today's session. Okay, 5 minutes break, and we'll come back, have some tea, have some water, refresh yourself, and then we'll come back and complete the today's class. Okay. guys, welcome back. Can you guys hear me? Okay. All right, so let's continue with our class. Our next question is, anyone had any question from the atrial fibrillation? So remember, if the patient is hemodynamically unstable, meaning he's going into hypertensive shock, patient is having heart rate below or more than normal, patient is having chest pain, and patient is complaining, or you see that the patient is having altered level of consciousness, then you need to do a cardioversion, right? DC cardioversion to the patient. If the patient is hemodynamically stable and is having sustained with the higher ventricular rate atrial fibrillation, like our patient had a 130 beats per minute one, you need to control the rate with beta blockers if the patient is having or not having any clinical signs of heart failure, followed by if the patient can have calcium channel blockers or not, digoxin or not, followed by amiodarone or not. Then ultimately, if you control the rate, you do the Chadwick scoring and anticoagulate the patient accordingly. All right. Next question is, a patient presented to emergency department with vomiting with a lot of retching after the vomiting. X-ray shows he has pleural effusion, and you diagnose the patient with the esophageal rupture, which is Borjeev syndrome. How will you proceed next? You will do pleural tap, you will do CT scan, give IV fluids, or give IV antibiotics. All right. So this patient is having Borjeev syndrome. They haven't mentioned anything about the hemodynamic stability. So we will just assume that the patient is hemodynamically stable. X-ray showing he's having pleural effusion, and you have diagnosed on the X-ray the patient is having esophageal rupture, Borjeev syndrome. How will you proceed next? We will do CT scan to see if the patient is having medianitis, also the extent of the esophageal rupture. All right. And whether we need to do a chest tube drainage or needle aspiration in this patient, or we need to do an endoscopy in this patient or not. IV fluids is not usually required in esophageal rupture, but if it is an esophageal rupture, and it is a one that is not having any further leakage, we would give after CT scan, we would decide to give the patient IV antibiotics. But if the patient is having like an esophageal rupture that is still bleeding, still leaking, causing pneumomedianitis, we need to proceed with the endoscopy, or we need to proceed with the thoracotomy to stop the or repair the esophageal rupture, okay? Is it clear, guys? So after X-ray, we do a CT scan. Always do a CT scan in esophageal rupture. And let's see if we can get the, just remembering, no, not this one. Okay, this one. So this has this, I just stumbled upon this one today. It has all the esophageal emergencies and their treatment available here, okay? All right. So our was a esophageal rupture. So if you look over here, foreign body, corrosive ingestion, and esophageal perforation. So esophageal perforation covers a large range of conditions characterized by transmural disruption of the esophagus. Spontaneous esophageal perforation is known as Borjeev syndrome, and it's most often due to abrupt increase in the esophageal pressure following a vomiting effort in the absence of relaxation of the superior esophageal sphincter. So against a closed sphincter, if you vomit, it causes an increased pressure in the esophagus that causes a rupture of the esophagus. It accounts for 15% of the esophageal perforations, and it's usually located on the left border of the lower third of the thoracic esophagus. The majority is iatrogenic and occurs during diagnostic and therapeutic procedures. Common denominator of all heterogeneous condition is the contamination of the esophageal contents into the surrounding areas, causing severe sepsis and death if it is not diagnosed and treated timely. Mortality of esophagus perforation ranges from 10 to 20. So it's very important that you diagnose it immediately. So what are the appropriate investigations? We start with the complete blood count, Chem 20, pH and lactate. What else? Contrast enhanced CT scan or CT esophagography is the imaging of examination in patients with the high suspicion of esophageal perforation. So this is diagnostic one. It's highly sensitive. It lets you know about the leakage of the air or fluid in the mediastinum, pleura, or intraperitoneal effusions, and guide the initial therapy. Indirect signs of esophageal injury can be seen on a plain chest radiograph, like pleural effusion, pneumonia, mediastinum, subcutaneous emphysema, hydrothorax, pneumothorax, and collapse of the lung. After CT scan, we can do diagnostic endoscopy, which is diagnostic and therapeutic as well. So if you're having a doubtful CT scan, but clinical suspicion of Borjeev syndrome is high, you can go for endoscopy. Even if your CT scan shows esophageal perforation, therapeutically, you can do endoscopy to repair the esophageal rupture, because it's gold standard for closing the esophageal rupture. So clipping, metal stenting, vacuum therapy can be done by the endoscopy. In patients with late presentations and patients who cannot have endoscopy, non-endoscopic esophageal perforation, you can use endoscopy as a first-line therapy. Okay. What are the indications for non-operative treatment? So those who have opted for IV antibiotics, this is the one. Non-operative management of the esophageal perforation can be considered in stable patients with early presentation and contained esophageal disruption with minimal contamination of the mediastinum. The criteria developed shows that most likely you will give patients IV antibiotics, and if the score is less than 2. Okay, so there's a criteria that you see. It's mostly on if the patient is not having any more leakage on the CT esophagography, patient hemodynamically stable, blood is not showing any signs of sepsis, then you can just give keep the patient nil by mouth, give them broad spectrum IV antibiotics and PPI therapy, and follow it with the early enteral feeding or total parenteral feeding so that you can allow the esophagus to heal. Indications of surgery is that all patients who are having ongoing esophageal perforation leakage, who are going into sepsis, and who are hemodynamically unstable should have repair of the esophagus by a surgery or thoracotomy. It can be done by a minimally invasive one, or you can do an open thoracotomy as well. Is it clear, guys? Yes, Borjeev syndrome is a complete rupture of the lower thoracic esophagus. So if the patient is hemodynamically stable, the perforation is contained, there's no further leakage on the CT esophagography, then you can basically nil by mouth, IV antibiotics, and parenteral nutrition. If the patient is not hemodynamically stable, patient is still leaking, pneumomediastinum, pneumothorax, pleural effusion is developing, you need to do endoscopy in the patient. If you can't do endoscopy, you can go for the minimally invasive laparoscopic thoracotomy. This one. So patient is just developing pleural effusion. X-ray has been done. You diagnose the patient as Borjeev syndrome. You will proceed with the CT scan. If the CT scan shows patient is having ongoing esophageal leakage, then go for endoscopy. If the patient is getting hemodynamically stable, you can go for the thoracostomy. Clear, guys? No worries. All right, next question. This is also one of the important topics. A young male patient with a history of orchidopexy of the right testes present to the GP clinic with the right testis larger than the left one. You have ordered an ultrasound which shows there is a cystic lesion. Which one of the following is the next step of investigation? Surgical exploration from the inguinal route, surgical exploration through the scrotal incision, or blood tumor markers? Very good. So whenever a patient is coming with some query regarding testicular cancer, especially a high-risk patient who had orchidopexy before, and there's enlargement of one part of the testes as compared to the other, the first thing we do in the GP setting or any OPD setting as well is do an ultrasound. After the ultrasound, we do blood markers for the cancer, which is beta HCG and AFP, I think. So if you look over here, this is the diagnosis and treatment of the early stage testicular cancer. If there's a testicular mass, in initial consultation, we order a testicular ultrasound and blood markers, which is AFP, beta HCG, and LDH. If testicular ultrasound and the blood markers, you can't see, okay, and let me just enlarge it. It's a very small one. It's kind of blurry as well. Is it better now? I try to magnify it. I hope it's better now, guys. Okay, so if the testicular ultrasound supported by the markers is telling you there is a testicular mass, then you can go for inguinal orchidectomy, or you can do a testis sparing surgery. All right. If there is a confirmed diagnosis of there's a confirmed diagnosis of a germ cell tumor, then you do the staging by the CT scan of the abdomen and pelvis contrast, CT or X-ray of the chest, and blood markers to measure after the orchidectomy. Okay. It's a simple one. Whenever there's a testicular mass, ultrasound and blood markers, then you can proceed with biopsy and orchidectomy. Orchiectomy, sorry. Okay. And staging always requires CT of abdomen, pelvis, chest, and the serum blood markers helps you regarding the progression of the disease or the regression of the disease. Yes, just like thyroid swelling. But in thyroid swelling, we do first the thyroid function test and then ultrasonography. If all tumor markers are negative and it's just a simple cyst, then yeah, accordingly, we do either drainage of the cyst or the removal of the cyst. You can do it through the scrotum or through the inguinal, depending upon the size of the cyst. When we do biopsy, when the ultrasound and the blood markers has confirmed that indeed it is a testicular cancerous mass, then you do the biopsy. Okay. Any question, guys? Got it. Okay, that's good. Next question. A 2-week-old baby developed jaundice on 3rd day. Still has a total bilirubin of 335 micromole per liter. Which out of the following is the best option for this baby? Phototherapy, observation and repeat the liver function test after 24 hours, exchange transfusion, or no further investigation is required? All right, so A and B. Can anyone justify A and can anyone justify B? Because we don't do exchange transfusion or further investigation is not required in this baby, is not possible. Bilirubin is quite high. So anyone can explain phototherapy in a patient, in this patient? So phototherapy, what are the indications of it? Yes, less than 360, we can do phototherapy, but what is the indication for that? Should it be a physiological jaundice or pathological jaundice? Pathological jaundice, right, guys? We do phototherapy, exchange transfusions always in the pathological ones, and pathological ones happens in the first 24 hours or more than 2 weeks of jaundice. So this baby developed jaundice on this 3rd day, and it's just 2 weeks. So approximately 11 days old baby with a jaundice of 335. It's not a pathological jaundice. It will become pathological if he is still having total bilirubin of this amount after 14 days, right? Then it will become pathological jaundice. But the first 14 days from the 3rd day, it's still a physiological jaundice. So we will just observe the baby and repeat the bilirubin levels. If after 2 days or after completion of the 14 days, the baby is still not having the resolution of the jaundice, then this baby is for phototherapy or exchange transfusion according to the normogram. Okay? Clear, guys? Sometimes, in very rare cases, patients with the physiological time period can have pathological jaundice if they are having signs of kernicterus. Okay, so physiological jaundice is a mild form of jaundice, very common in the infants. In term infant, very quickly rises by 3rd to 5th day, decline rapidly before fading over the next 1 to 2 weeks. Management can include phototherapy, but if it is more than or in the required range. Pathological jaundice happens within the first 24 hours of the patient being born, and it's because of the ABO incompatibility, RS isoimmunization, hematoma, and when the conjugated bilirubin is more than 340. So if in the hyperbilirubinemia of the pathological jaundice, patient is having more than 285 micromole per liter of unconjugated hyperbilirubin, we go for phototherapy, and if it is more than 360, exchange transfusion. But our patient is just 11 days old with what was the range? 335 micromole. If after 14 days, he's still having this much, then this is pathological jaundice. You need to start the phototherapy. This is the total bilirubin value. Okay. In total bilirubin, you need to find out what is the unconjugated, what is the conjugated one. They haven't given you any unconjugated or conjugated one. If the patient is having pathological, more than 15% is hyperbilirubinemia, 2 weeks baby, but the jaundice start from the 3rd day. So it's still 11-day jaundice. Not if the jaundice is more than 2 weeks, maintaining the hyperbilirubinemia, then that is the pathological jaundice. This one, guys, pathological jaundice. Guidelines for treatment of the hyperbilirubinemia at 24 to 36 hours. Okay, that is for the pathological jaundice. After 2 weeks, this jaundice will become pathological jaundice. Pathological jaundice happens within the first 24 hours. And if the jaundice is persisting more than 2 weeks at a high values, then that is pathological jaundice. Less than 14 days baby, they usually have physiological jaundice if it doesn't happen on the 1st day. So we need to wait to see if the jaundice decreases or not. If it is not decreasing, this physiological jaundice will become pathological jaundice on 14th day, and we need to start treatment for that, which is basically phototherapy. Clear? Okay. No. This is the total bilirubin. So when they will give you unconjugated, conjugated one, look for the unconjugated one. If unconjugated one is 286 in the pathological range, then that is for phototherapy. If it is more than 360, that is for unconjugated hyperbilirubinemia for exchange transfusion. If the total bilirubin has more than 15% of the conjugated one, this is the conjugated hyperbilirubinemia, and you don't do phototherapy and exchange transfusion for that. You need to rule out the causes of it, which is galactosemia, biliary atresia, neonatal sepsis, things like that. Okay. A patient with post-streptococcus glomerulonephritis on dipstick having 3 to 4 per positive proteinuria. How will you diagnose the disease? Kidney biopsy, urine microscopy and culture, or ASO titer? Titer, sorry. Very good. So dipstick has already been done. The next step is we do the evidence of the infection, which is by ASO titer. The next thing which we do is the complement level. So always remember, if you don't have dipstick, do the urine analysis and microscopy first. Then the second one is the ASO titer. The third one is the complement level in the PSGN. So very common in the Aboriginal community. So that is why there are very strict guidelines that you have to follow. So at least 2 of the following: facial edema or peripheral edema with hypertension with moderate hematuria on the dipstick. Any question concerning, laboratory evidence is required. So hematuria on microscopy or dipstick, doesn't matter. Either of the 2 should be present, and evidence of the streptococcal infection by ASO titers or anti-DNase antibody, and you need a complement level in which the C3 level would be reduced. This is the laboratory diagnostic criteria for PSGN. Okay. Clear, guys? So urine microscopy and culture or dipstick, number 1. Number 2 is ASO titers or anti-DNase antibodies. Number 3 is complement level in which C3 will be low. Treatment of the PSGN is fluid restriction, increased carbohydrate diet, treatment of the infection, that's it, and treatment of the hypertension. It's a symptomatic treatment. We don't give anything. In IgA nephropathy, we give steroids. In PSGN, we don't give anything. We just do symptomatic treatment with fluid restriction, blood pressure control, carbohydrate increased diet, and antibiotic treatment if required. If there is evidence ASO titer is positive, then we also give antibiotics. But other than this, there is nothing we do. It's more of a surveillance thing. Urine microscopy has already been done. Either you do urine microscopy or you do a dipstick. You don't need to do both of these things. So the answer is ASO titer. And the next thing you will do is the complement level. You have to do all three things in order to diagnose a patient with the PSGN. If they haven't done the dipstick and showed you hematuria or proteinuria, then definitely the first thing you will do is dipstick or urine microscopy. Okay, next question, guys. There was a school kid, 11-year-old, who won't listen to teachers, will run away from house for a few days. Father was violent with him and always fought with the father, but was happy with his siblings. Which one of the following is the probable diagnosis for him? Oppositional defiant disorder, conduct disorder, or antisocial disorder. So we know that any kid who is having authority issues but is fine with the peer age group, this is the oppositional defiant disorder. Conduct disorder, antisocial disorder is the same thing. The difference is just with the age. Less than 17 years of age, conduct disorder, more than 17, antisocial. Both of them are criminals. Vandalism, not caring for people's rights, not caring about their properties. They are basically criminal-minded people. So let's have a quick review of the oppositional defiant disorder. So oppositional defiant disorder is a childhood behavioral problem characterized by constant disobedience and hostility towards the authority figures. Okay, it's usually around 10 to 12 years of age, more common in boys than in girls. It's associated with disruptive behavior disorders like conduct disorder and attention deficit hyperactivity disorder. Early intervention is required. So they will become easily angered, annoyed, or irritated. They have frequent temper tantrums. They argue frequently with the adults, especially the most familiar adults in their lives, like parents and teachers. Refuse to obey rules. Deliberately annoy or aggravate others. Have very low self-esteem, low frustration threshold. Blame others for their accidents or bad behaviors, but they have a good relationship with their peers or with their age groups. So conduct disorder, refuse to obey parents or authority figures, truancy, use drugs, lack of empathy, spiteful or vengeful behavior, aggressive to animals, aggressive to people, bullying and physical or sexual abuse. Gangs, physical fight, using weapons, lying, law-breaking behavior, runaway, learning difficulties, low self-esteem, suicidal tendencies. These are conduct disorder. Less than 17 conduct, more than 17 antisocial disorder. Okay. Any question, guys? All right. 41-year-old lady with the PCOS feature. Her sugars are 6.1 and she is obese. How will you follow that the treatment was a success? Serial ultrasonography, HbA1c, measuring the weight, or regularization of the periods? Her sugars are 6.1. How will you know that PCOS are responding to treatment? B, guys. They have specifically mentioned PCOS feature with high glucose levels. So how will you know that PCOS are being controlled? You will follow her HbA1c. If they have mentioned 41-year-old lady with PCOS feature, irregular periods, how will you follow treatment success? Regularization of the periods. 41-year-old lady with PCOS feature, obese, how will you follow treatment success? Decrease of the weight. 41-year-old lady with PCOS feature, infertility, how will you follow treatment success? Serial ultrasonography and fertility charts. All right. If they have mentioned a specific symptom after mentioning that she is diagnosed with PCOS, then you will follow that symptom to see how she is responding to the treatment. Okay. Because PCOS have dominance of features. Sometimes weight is a problem. Sometimes periods are problems. Sometimes blood sugars are problems. Sometimes acne are problems. Sometimes hirsutism are more prominent problems. Sometimes infertility are more prominent problems. So you need to figure out what they have mentioned as a basic symptom the patient is having problem with. And then you follow accordingly to her. Okay? Clear, guys? All right. Any question from that? All right. A patient is coming to you in the emergency department with the acute right upper quadrant pain. There is a stone in the neck of the gallbladder, either by a CT scan or by ultrasound. And she is also having cholangitis features. You started antibiotics, but the condition worsens. What will you do next? ERCP, MRCP, percutaneous cholecystectomy, or cholecystectomy once sepsis settles? Excellent. So whenever a patient is having cholangitis with gallbladder stone, then we need to decompress the gallbladder. Biliary decompression is required, otherwise this patient will go into sepsis. So antibiotics, IV fluids, NBM followed by ERCP. Okay. If ERCP is able to decompress the gallbladder, well and good. But if there is a gallbladder full of stones and you have done the biliary decompression, following ERCP, you will do cholecystectomy as well. Okay. Clear, guys? Okay, so you can study the biliary colic from RSCGP. They have written it really well. So clinical presentations of gallstone is female, increasing age, family history, rapid changes in the weight, ethnicity. Acute cholecystitis infection of the gallbladder presents with the right upper quadrant pain, raised temperature, tachycardia, and occasionally a positive blood culture. So in acute cholecystitis, we do early cholecystectomy. Acalculous cholecystitis, again, cholecystectomy should be done. CBD stones, some patients have dilated gallbladder by a stone in the CBD. So whenever there is derangement of the LFTs along with the right upper quadrant pain, then you would do ERCP. Okay. Cholangitis. Cholangitis requires urgent ERCP to drain the biliary system. Afterwards, you can do cholecystectomy once their sepsis has settled down. Okay. So ERCP here. Good. Okay, this is an easy one. A nursing home resident became violent to the carer and fellows suddenly, but was previously fine with them. What to do next? Shift to dementia specific ward or shift to emergency to rule out delirium causes. So this is a very straightforward one. If there is a constant behavior, you don't need to shift the patient to the emergency. You can shift the patient to the dementia specific ward if it is a constant decline in the function. But if it's a sudden change in the behavior, sudden change in attention, sudden change in orientation, sudden confusion in a patient, you need to send the patient to emergency because we need to rule out dementia in this patient. So sudden changes can be a sign of infection, pain, or side effect of a medication. Do not assume that behavioral personality changes are always because of dementia. There is delirium as well that you need to rule out in these patients, okay? All right. This is also a very easy question. A COVID patient who was wife. Husband also developed features. What will you do next? Shift to emergency, send swab and isolate the patient. Isolate or start the antiviral therapy. I think you all are aware about the COVID guidelines. If the patient starts exhibiting the symptoms, what do? We send the swab and isolate the patient. So you can see the COVID-19 guidelines from any of the territories. All are the same. So stay at home to isolate if you're having symptoms. Avoid communities for at least 7 days. Wear a face mask if you are unable to physically distance yourself. So symptoms, we all know: headache, muscle ache, fatigue, nausea, vomiting, diarrhea, fever. In elderly, the symptoms is delirium as well. So you should get tested if you are having symptoms and report a positive test to the Queensland Health. And if you are feeling sick, stay home, isolate, and you can order a rat test as well. You can do a rat test from home. So send your swabs or do a rat test and isolate yourself. And take paracetamol and ibuprofen as required, but don't exceed the maximum dose in a day. All right. A foul-smelling stool for 1 month in a lady. No bloody stool, no abdominal distension, but she is getting pale and getting ulcers around the mouth. What is the probable diagnosis? Jaundice, Crohn's disease, or celiac disease? Okay. Why are you guys thinking of jaundice? When should you think of jaundice? Can anyone justify when do we think of jaundice? There are specific things in a question to look for when you're thinking about jaundice. Very good, Dr. Saman. Travel history should be there. Travel history should be there in jaundice. Why are we not thinking of Crohn's disease? Crohn's disease is not just for 1 month. It's 6 months. It's a chronic disease. And in Crohn's disease, you just don't have diarrhea. We don't have smelly diarrhea in Crohn's disease. It's alternative with constipation. You have perianal ulcers, eye features, extra intestinal manifestations as well. So this is not Crohn's disease. This mostly looks like a celiac disease. So 1 month history, getting pale, and getting ulcers around the mouth. This looks like an iron deficiency anemia in the celiac disease. So pretty much this patient should have a celiac screening done because she is starting to have the symptoms of the malabsorptive syndrome. So what are the criteria? What are the features of the celiac disease? There is diarrhea, recurrent mouth ulcers, developmental delay, fatigue, unexplained abdominal pain, irritable bowel syndrome, which improves with the gluten exclusion, skin rash, which is typically itchy and blistery. This is dermatitis herpeticum. Gluten intolerance as a child, nutrient deficiency like iron, folic acid, vitamin D, and B12, anemia, osteoporosis, insulin-treated diabetes with poor glycemic control, sometimes thyroid disease, because this is a autoimmune disease. It can come with hypo or hyperthyroidism, liver enzyme disturbance, vitamin B12 disturbances can cause unexplained neurological complaints, infertility and miscarriages, colitis, IgA deficiency, Sjogren syndrome, Addison disease, and Downer-Turner syndrome is associated with it. So whenever you see a patient coming with these, we do screening of the celiac disease, which is IgA, endomysial, and transglutaminase antibodies. And we do a duodenal biopsy of the duodenum to diagnose a patient. So screening is the IgA deficiencies, which is anti-transglutaminase, anti-endomysial, anti-gliadin antibodies. Genetic testing is not usually done, but duodenum and jejunum biopsy is done. The treatment is gluten-free diet and supplements. That is the best treatment for it. All right. Any question, guys? So this patient is having wrist drop with finger drop. Which one of the nerve is damaged? Very, very easy question. If there is a median nerve damage, what will happen? Can anyone tell me? If the median nerve is damaged, ape hand. If the ulnar nerve is damaged, claw hand. Very good. So if the radial nerve is damaged, we call this radial nerve palsy. So this is the radial nerve, which supplies the extensors of the arm and hand. So it will cause wrist drop with finger drop. Good. A 52-year-old lady is postmenopausal for 6 months. Is coming with hot flushes and other menopausal symptoms. What kind of preparation of HRT you will give to the patient? Cyclical estrogen or progesterone, continuous estrogen and progesterone, estrogen only, or progesterone only? So this is one of the most repeated questions of AMC. I think I have seen it in all February, March, and April now. So this patient is having 6 months. Very good. So if the patient is having less than 1 year of postmenopausal symptoms, then we give cyclical estrogen and progesterone. If the postmenopausal is more than 1 year, then we give continuous estrogen and progesterone. If the patient is not having uterus, what do we give then? If the patient is not having uterus, but having postmenopausal, very good, we give estrogen only. So in this way, guys, you have solved 3 MCQs with me. What are the instances in which we give progesterone only? When do we give progesterone only? In a postmenopausal female. We never give progesterone. We don't give progesterone alone in a postmenopausal female, okay? We only give progesterone with estrogen in a postmenopausal female in a uterus because we want to prevent the uterus from having harmful effects of the estrogen. But if there is no uterus, then we give estrogen only. If less than 1 year of postmenopausal symptoms, we give cyclical ones. If it is more than 1, it's an established postmenopausal, so we give continuous estrogen, okay? So if you look over here, this is RACGP guideline prescribing the hormonal treatment for women with no contraindication. If the uterus is intact, we give a combined hormonal treatment, estrogen plus an endometrial protection one, which is progesterone. If the patient is having less than 12 months, then you give cyclical progesterone with continuous estrogen, cyclical progesterone with continuous estrogen, transdermal one, with cyclical oral one, and you can also give it IUD as well. But if the patient had hysterectomy, you give estrogen only. If it is more than 12 months, then you give continuous estrogen and progesterone. Okay? Clear? Any question, guys? All right. A patient comes in with severe, where there's no instance where we give only progesterone. If the postmenopausal is less than 1 year, then you can give contraception to the postmenopausal females, because they can still get pregnant if the postmenopausal is not established for 1 year. Patient comes with severe pain. Doctor prescribes morphine. Nurse decided that patient doesn't need morphine and give paracetamol. Patient is still in pain after some time. What should the doctor do next? Report to the AFRA. Tell the nurse about the impact. Say you don't want to work with this nurse again. So whenever there's a doctor-nurse conflict, the best way to solve is talk to the nurse about what she has done and teach her gently about why you have prescribed morphine. And if she still disobeys you, then you escalate the matter to the nurse head, not to the AFRA. AFRA can only be done by the director of the nursing staff if they think that the nurse or the doctor is being very disobedient of the ethics. All right. There was a bipolar hypomania patient who has not been compliant and had very low lithium levels. What will you give now to control his symptoms? Lithium, olanzapine, valproate, or carbamazepine? Same thing that you do. You never report to AFRA in the first instance. So the patient is non-compliant with lithium and has very low lithium levels. What do we do in order to control the bipolar disorder? Very good. We add an antipsychotic. Change the medication. Very good. First line is antipsychotic. Then we give maintenance with the lithium or sodium valproate. But if the patient is maintaining on lithium or sodium valproate as a mood stabilizer, and still patient is having psychosis, we add an antipsychotic as well. Okay. So lithium is always given with the antipsychotic in the maintenance therapy, especially in the patients who are having fluctuating symptoms of hypomania and mania. Okay. Is it clear, guys? So this is for your Royal Australian New Zealand College of Psychiatrists. This is very, very important for your exam. Do study it from here. So that's it today for today's class, guys. I hope you had a good session and I was able to tell you about how the course is going to be and how the exam happens and how we help you guys basically in preparing that. So I hope I will see you guys in the course. Thank you so much. Take care. If you have any questions, do let us know by contacting Dr. Arshan via Messenger, okay? Thank you and take care. Have a good night.